family, hello friends. This is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, in this video, I'm going to be talking about the real reason, or be explaining the real reason why NSAIDs are horrible for diabetes and hypertensive patients. So let's just say NSAIDs and diabetes plus hypertension. I'm just going to give you a common clinical scenario that is so common if you are working in OPD, outpatients, like working at a polyclinic or even in internal medicine. Very difficult patients to manage, not easy. It's so frustrating to manage them. So these patients, it's very common for us to see a patient. First of all, it's an elderly patient. Number two, they've got diabetes. Number three, they've got hypertension. And number four, they've got osteoarthritis. Sometimes, even if they only have these, and they're not necessarily old people, the fact that they've got these bottom three, it's very difficult to manage these patients because they will come in with pain from the osteoarthritis, but you know very well that you can't use NSAIDs, especially if they've got a proven nephropathy, be it from the diabetes or from the hypertension. It's very difficult. So with this kind of patients, you don't want to use NSAIDs, but you still want to manage them well. You still want them to be pain-free. At the same time, you can't give them too much steroids because you're going to get the complications of the steroids, which one of them is an increase in the blood sugar. Now, if you give them too much steroids because you want them to be pain-free, you'll be worsening the diabetes. At the same time, if you say, which is often what we do, we combine paracetamol with some weak opioid. But you know, opioids have got their own problems. There's addiction, there's constipation, and the list goes on. So it becomes very difficult because they will keep coming and complaining with pain, and these drugs are very potent in terms of controlling pain. But in this setting, you don't want to use them. And at this point, I don't know how safe it is to give a patient NSAIDs who's diabetic, hypertensive, and is also old, in the absence of a proven nephropathy. Because you might say, I'm going to give them NSAIDs, and that is just enough to push them to nephropathy. You may never know. So it's very difficult. So this is why we really need sometimes to consult from the internal medicine side about these patients. Remember, NSAIDs, why do we give NSAIDs? We give NSAIDs because they are potent anti-inflammatories. I know that there are people who prescribe NSAIDs to this kind of patients without even thinking twice. But if you go to places that are very academic, you will know that it's no longer done. But anyway, anti-inflammatories, they are also antipyretics. They are also good analgesics. This is why we want to give them. Because remember, when you've got a patient with osteoarthritis, you want this anti-inflammatory effect, you want this analgesic effect for them, right? They work very well if you add, on top of that, you add a steroid. Work very well. They are very good. The combination works very well in terms of controlling the pain. But this is the situation that you have. Okay. In order for us to understand why this combination is bad, we need to go back to understanding NSAIDs just briefly, and then move on to the renal. In this particular video, I'm just gonna focus on the NSAIDs. Then on part 2, I'll focus on the renal and just finish the topic off like that. So there's gonna be part 1 and part 2 of this small talk. Okay, so let's talk about NSAIDs. NSAIDs are non-steroidal anti-inflammatories. Remember, steroids are good anti-inflammatories. They're very good anti-inflammatories. NSAIDs, I just want to understand, to make you understand this part. So they are non-steroidal. Steroids are good anti-inflammatories. So these ones are non-steroidal. So they are still potent anti-inflammatories without the steroids. Like I'm saying, steroids are very potent anti-inflammatories. So these ones, they are good anti-inflammatories without the help of steroids. They don't have steroids in them. Okay, let's talk about now how do they actually work. So, let's classify the steroids first. Okay, let me say, in the body we've got what we call arachidonic acid, which is a lipid. So this arachidonic acid, we want it when you are injured. Let's say you are injured. Maybe you got burns or you hit yourself with a hammer or whatever. When you are injured, you want to get better. You want healing. Now, for healing to take place, you need inflammation. Inflammation is the first process, or the first step into healing. So, but inflammation, how do you get that cascade of inflammation and all of that? So you need these guys. You need prostaglandins. You need prostacyclins. You also need prostacyclins. You also need thromboxane. So, for you to get these guys, you need to convert arachidonic acid to give you those 3 guys. But to convert arachidonic acid into prostaglandins, prostacyclins, and thromboxane, you need a special enzyme called